This is Dr. Howard Strassler. Today's lecture, Module A, Initial Procedures for Operative Dentistry, Local Anesthesia. And you might think, why am I lecturing on local anesthesia when this is an operative course? And in fact, local anesthesia really is the first step to what you'll be doing in operative dentistry. Once you've done the exam, in most cases you're going to pick urgent care. You'll pick situations where the patient needs a restoration. And so I'll be talking about local anesthesia, building on the information you'll get from oral surgery in their local anesthesia course, but I'll be relating it to restorative dentistry, how being able to administer local anesthesia well really helps develop a better relationship between you and the patient, allows you to perform your procedures at a higher level, having the patient numb, and we'll talk about the choices of local anesthesia in the clinic. I mean, let's face it, do you want to be a hero? If you can administer local anesthesia painlessly and profoundly, your patients will remember that. Your patients will tell other people that they have a dentist who, when they get them numb, they don't feel a thing. And that is something that you should be proud of and something you should be trying to get to that level. Administering a local anesthetic agent painlessly and profoundly, that the tooth is numb, that the gingival tissues are numb. Well, first you have to start with what needle you're going to use. And in the clinics, our predominant needles that we're using are, in fact, 27 gauge long needles and 30 gauge short. Within most private practices, you'll also see 27 gauge short needles that are being used. 27 gauge long needles for mandibular blocks, posterior superior blocks, where you need that length in order to place the needle and to be able to place it in those areas of the soft tissue where you can get profound anesthesia. A 30 gauge short needle is predominantly for an infiltration, a maxillary infiltration. Although if you're using the local anesthetic Septicane, you can in fact do mandibular infiltrations from the second premolar forward, and you can use a 30 gauge needle to do that. Keep in mind that the larger the gauge, the larger the diameter. So 27 is a larger diameter than 30. That needle will stay sharper. And that's important when it comes to when there's the need to re-inject the patient using the same needle. And when you look at length of needles, you're speaking of different lengths, different diameters for different use. The 30 gauge needle is the blue cover, 30 gauge short. The 27 gauge long needle has the yellow sheath that we'll be using. And don't forget good practices when resheathing needles to use the special tool that you can get at Prep Dispense for resheathing a needle to avoid needle sticks. One could also resheath needles via that there's a holder within the operative cassette. So when do you change the needle? You change the needle after 2 injections. A disposable needle is less sharp, and rather than a penetrating smooth insertion, the needle will create a puncture wound within the soft tissue, increasing the possibility of soreness. If you hit the bone with the needle tip, you should change the needle. Once again, you're dulling the needle. And so 2 injections are the most. In fact, if after 2 injections you don't have the patient numb, you should call a faculty member over. How profound are mandibular blocks? And in fact, infiltrations are fairly routine, getting the patient numb. Mandibular blocks can be much more challenging. In fact, when I have a patient where I'll be working on a mandibular molar, one of the questions I typically will ask if I see other restorations is, when the restoration was placed the first time, did the patient get real numb? If the patient tells me that, oh, the dentist could never get them numb, then I'm thinking about other means to get them numb than a typical block. I may be thinking of using a Gaugates. And if you look at how often do you see a missed inferior alveolar block, 50% of the injections we give are blocks, with a 5 to 15% failure to achieve profound anesthesia. And where that becomes important to you is, as a beginner, as a novice just learning, that rate in fact goes up. So why do we see local anesthesia failures? Well, we see local anesthesia failures due to anatomic variations as a cause of failure. We see local anesthesia failures because of technical errors. You're either too low or too high, or you're not deep enough. If you get an intravascular injection, and keep in mind, whenever you're administering local anesthesia, you should be making sure before you insert the needle that the harpoon of the syringe is engaged in the rubber stopper, so that you can aspirate as you're giving your injection. And it's not just one aspiration, but in fact several as you're administering anesthesia. So you think about the reasons. Well, anatomically you're not placing it in the right area, but also a very anxious patient. The patient may not think they're numb because as you're preparing the tooth, they feel the vibration, and to them it's pain, and it may not be pain. In fact, for some patients who are extremely numb, that the idea that they can hear the drill and feel the vibration of the handpiece triggers to them that it's going to hurt. A tooth that has an inflammation or infection may be difficult to get numb. Certainly an abscessed tooth, when trying to extract that tooth, it may be difficult to get that tooth numb enough to extract it. And you may need multiple types of injections to get that site numb. Defective anesthetic solutions, and really using a drug that's past its expiration date, or perhaps the product wasn't formulated correctly. This is very rare, but it has happened, has been reported in the dental literature. So let's look at the anatomic basis for a successful inferior alveolar block. Well, first note the site of initial penetration. What I want you to notice is on the lower left-hand side where the finger's placed. The finger's placed palpating the notch of the ramus. Not the outer portion of the border or the inner, but actually that notch. You're then going to center the needle stick in the pterygomandibular raphe. You're going to position the syringe coming out over the premolars on the other side, the first and second premolar, and you're typically going to go about 2/3 the length of a 27 gauge long needle, that depth of penetration, before anesthesia. And I talked to you about the being on the notch of the ramus. If you look to the right hand side, you can see where the thumb is positioned and stable. Now, if you're having a hard time because it's you're right-handed and you're working on the right-hand side, then you can use your pointing finger. But you want to palpate that notch of the ramus. So how do you achieve a comfortable, reliable injection? Well, first of all, use a new needle. If you've working in several different sites, giving infiltrations with a 30 gauge needle. After 2 injections, absolutely put in a new needle. Use topical anesthetic on the area that you'll be administering the anesthesia, and let the anesthesia sit there long enough, not 5-10 seconds, but rather 45 to 60 seconds for the topical anesthetic to work. Pull the soft tissue towards the needle as you're injecting, so that the needle is actually penetrating the soft tissue, and you're not pushing on the tissue, but you're penetrating it. It's a surgical placement. You can distract the patient. While injecting, move the cheeks and lips, sort of wiggle it about. And one of the things that I do is I administer the anesthesia very slowly, 10 to 30 seconds, while I'm distracting the patient by wiggling their lip. I'm just making sure that I'm not injecting it so fast that the patient can feel the injection. In fact, with Septicaine, when you're injecting it slowly, the anesthetic has a more rapid onset, and in fact, within 10-15 seconds, the patient is numb in the soft tissue area. And as I mentioned earlier, for patients who have a history of not getting numb with inferior alveolars, with mandibular blocks, consider a Gale-Gates high block technique. And when doing a Gale-Gates, have a faculty member help you with that technique. But this again is for patients without a history of getting numb. So if you've administered the anesthesia and you wait 4 to 5 minutes by the clock, which gives you a chance to place the dental dam, which will be Module B of these presentations, and you'll be ready to go. Now, before you start your preparation, you're going to be placing the dental dam. Check for pulpal anesthesia. How do you check for pulpal anesthesia? Well, I'm not going to take a sharp explorer and stick it into the gingiva. I mean, lip signs for a mandibular block, being able to stick an explorer into the soft gingiva without pain, that means the soft tissue is numb. That doesn't mean you have pulpal anesthesia. To really know you have pulpal anesthesia, do a cold test of the tooth. Which patients do I do this for? Do I do it every time I administer local anesthesia? No, I do it for those patients who have given me a history that they were hard to get numb, that when the dentist did fillings for them, it always hurt. For patients who are very anxious, I want to demonstrate to them that the tooth is numb. Because once you pass the enamel, get into the dentin, if there is no profound pulpal anesthesia, the patient's going to feel it. They're going to have doubt as to whether they're numb from that point forward, even though you tell them they are numb. In fact, when you talk to some people, you'll have some people tell you that I was told I was numb, and the dentist proceeded and it hurt like heck. So make sure the patient's numb before you start your tooth preparation. So win your patients over. You've administered anesthesia, you've done a procedure where there can be post-operative discomfort later in the area. Call them that evening. Reassure them any discomfort they're having, whether it's cold sensitivity, whether the soft tissue is uncomfortable, is normal. If pain's unexpected, see the patient as soon as possible. Throbbing pain, pain that's not going away, a filling that's high in occlusion. You've just heard initial procedures for operative treatment, Module A, local anesthesia.